Hello, everyone. I think we are live. I'm seeing that we've got people here, I believe. We're using a new setup with Riverside today, so I am use the chat to say hello, so I know that people are here and that this is working. Drop in your names, where you're from, and we'll get going on the conversation soon. We've got our panelists here today. I'm so grateful to the team who are joining us in this discussion. I think we've got one other to join who just dropped off, so bear with us as we move through this conversation. But a big hello to everyone. Thank you all so much for joining us. And just by way of introduction, I just wanted to set the scene a little bit. So my name is Rachel. I'm the founder and managing director of Comotion. We are a social change agency, and we work in strategy, campaigns, communications, program design, and across the areas of gender, maternal health more broadly. And so this project has been a labor of love and something that I have been really, really personally excited to do and take part in. So yes, thank you for joining us for this panel, a feminist perspective on addressing the maternal health crisis. As I said, please do introduce yourself on the chats if you're just joining. And I just wanted to start the conversation by acknowledging and thanking Global Fund for Women and FCDO for partnering with us on this program. At its core, this collaboration is about shifting from top-down global development models to locally driven policy and programming for maternal and newborn health. Our goal is to move funding closer to communities and deliver outcomes that reflect their priorities. I have worked for many, many years in the maternal health policy space, and in more recent years, working closely alongside feminist funds and feminist movement building community. And what I can say is that this project feels both unique and urgent, particularly in this current geopolitical context. It really bridges two spaces that are deeply connected, yet too often siloed. Maternal health has for a long time been treated as a narrow, technocratic issue, allocated small portions of health budgets and with narrow metrics that leave out a lot of the context as to why we're seeing some of the indices that we do. And while there's been a prevalent conversation for many, many years on the need to move money closer to the local groups and communities, we've really not had clear mechanisms to do so effectively. And for a large part, the aid architecture has made that difficult to do so. Meanwhile, in the gender justice space, while there have been very strong mechanisms for moving money to local groups and movements, maternal health itself has been quite absent from some of the portfolios of these groups. And so this initiative is really the chance to change that and bring these two worlds together and be more impactful in our funding for maternal and newborn health. So what do we know? We know that health systems in many countries around the world were designed in the image of colonial administrations, highly centralized, often hierarchical and exclusionary. And these legacies still shape whose voices are heard, whose priorities matter, and how money for these issues flows. Financing is channeled very often through accountability frameworks that often miss community realities and leave structural issues unaddressed. And so this history helps explain the disconnect that we see today between health policy and the priorities of these communities. So through this project, the initial stages of these projects, we did a comprehensive mapping across 5 countries, Ethiopia, Kenya, Malawi, Nigeria, and Sierra Leone, to understand what's driving injustice in maternal and newborn health today. And what came out of those consultations, came out from the communities, were key justice issues that we see very often largely absent from policy and accountability frameworks. Issues such as widespread obstetric violence, disrespectful care, GBV, FGM, these justice issues that affect so many women. Abortion care is very often excluded from policy frameworks, though cited as a high priority for many of these groups. A depleted and undervalued health workforce, for many that will not be new news, but continues to inform the maternal health indices that we see. having little or no funding, something that has been exacerbated by the recent happenings within the aid community, and even more urgently or scarily is the fact that in the absence, in that gulf in funding, we are seeing anti-rights actors filling that void and gaining significant influence at the grassroots level and really shaping that agenda. I'm going to throw it across to Shree shortly to speak a little bit more about that. But what these findings confirmed is what many of us have experienced, that there is a gap between maternal health policy and we're seeing a lot of the sidelining of some of these justice issues and the lived realities of the people. And the current aid system is in real time demonstrating to us its fragility. And while right-wing groups are very quickly filling that financing void, it is important that other donors are taking the opportunity to redesign their funding flows before we lose further ground. And so with that, I want to bring in the panel led by Shree, who has really been driving this project with our local partners to just add a little bit of color to what I've just shared. Thank you so much for giving us the time. I'm hugely grateful to the team who have been around this project and look forward to hearing from you all.
Thank you, Rachel, and welcome everybody. And good afternoon, good evening, good morning, wherever you are. We are really delighted to be here and present, this discussion really. So my name is Shree Mandke. I'm a strategic project director working for Comotion on this birth justice initiative. I'm going to be a moderator today, so really honored to be working with this fantastic panel of speakers, whom I will introduce later on. But just I really wanted to pick on what Rachel was saying about the disconnect. And I'm sure I'm hoping that in our audience today there are key stakeholders, policymakers, grassroots level organizations. And, I first wanted to touch on the connection bit rather than the disconnection bit. And the connection bit is happening. So, it's not all doom and gloom. And, there are certain things that are moving in right directions when it comes to justice-based demands. And you will see, especially those are on the policy side, working for governments or global actors or even local actors, is that, in your every women, every newborn, everywhere action plans, as well as collaborative advocacy action plans in your countries, you might have seen that, adolescent health and well-being is surfacing. And that's something that came up in our findings as well. So it's not a surprise. You would have seen that PMNCH, Partnership for Maternal and Newborn Health Global Partnership, has recently launched their strategic plan for 2026-2030, and it has surfaced sexual reproductive health rights, promotion of sexual reproductive health rights, which is very welcome initiative, as well as adolescent well-being. So, that's, I really wanted to start on that positive note in terms of connection and, why this particular, our birth justice initiative is such, is at the opportune time to be working on this with grassroots level organizations. But just going deeper into what that means for certain issues which Rachel has highlighted, and that they were widespread obstetric violence, gender-based violence, female genital mutilation, disrespectful maternal care. And, what we found, and these are the issues that are not surfacing in the policy arena. And these are thorny issues. These are issues which are, mired in, politics. It is about women's bodily autonomy. And we really wanted to start thinking about, what is it that is, not, these issues, especially what we found is that, lack of access to safe abortion care about 18% of maternal deaths in Malawi contributed by lack of safe abortion care access. You know, there is a morbidity attached to FGM. There is morbidity, maternal morbidity around gender-based violence. And these are the issues that really need to get surfaced into the policy documents. And I think in terms of, the shifting landscape of global funders, some of you may have actually, seen the America First Global Health Strategy and it prioritizing government level funding, funding through faith-based groups, as well as funding through private sector. And I think this is again, looking at what's happening around us and how we could take the opportunity to bolster the community-based activism so that community needs are surfaced to make the health system strengthened is going to be key for future of universal health. So I'm going to stop there. I really want to introduce the panel, but before I introduce the panel, I would like to ask the audience to feel free to start asking questions to the audience using the chat function. When you ask the questions, please tell us who you are, which organization you work for, and where you are based. And my colleagues who are working in the background, they're going to collate these questions. And if we have time towards the end of this session, some of those questions, I will be posing them to our wonderful panelists. So let me start introducing the panel today. So I'm going to start with Kemi Akinfaderin. So many of you will have known Kemi. She is the Chief Global Advocacy Officer at Feminista and is a well-known feminist thought leader with over 20 years of experience in movement building and trust-based grant making. When I looked at her brief bio, I was so delighted to see that she co-founded Education as a Vaccine in Nigeria, because there is a connection there, because Education as a Vaccine is a coordinating organization for PMNCH collaborative advocacy action planning. So, that's fantastic, Kemi. Welcome to the panel, and we are really grateful for your time today. I know you are very busy. You are at UNGA, running around, so thank you very much for joining us. I'm going to now move on to Faith Mbehero. Faith is a health system and SRHR leader with over 20 years of experience spanning clinical practice, program management, and global partnerships. Faith founded Kenya's first reproductive health network of providers, and recently, after stepping down from Global Parent Parenthood Global, she recently co-founded Third Sector Builders, Pan-African consultancy. Faith is also working with us in terms of identifying movement actors in Kenya. So thank you very much, Faith, for joining us. We are really grateful to your time and really looking forward to hearing your insights. So thank you. Now over to Sybil. Sybil Nmezi is a founder and executive director of Generation Initiative for Women and Youth Network. And she has been leading the organization, the network, for over 20 years, advancing gender equality, women's empowerment, and sexual reproductive health rights. So Sybil, thank you very much for your time. We are really looking forward to hearing from you, your insights, and what you have found today. So while I'm introducing you, I'm going to start with you, Sybil. With the question, and it's kind of a a really obvious question about, was there anything that surprised you about the findings of the report, And if not, why do you think there is still such a disconnect between health policy and funding, largely focused on health system strengthening and what communities are saying their biggest issues and priorities are? So over to you, Sybil.
Thank you, Shree. And I thank you, panelists. Well, I will say that the finding did not surprise me at all. The funding does not surprise me at all. We live these realities every day at GIWYN because we are there with the grassroots women. A mother once told us, they shouted at me, okay, they, hello?
We can
Okay,
hear you,
okay,
Sybil.
thank you. A mother once told us, they shouted at me more than they cared for me. We believe that sums up the crisis of dignity in care. For us, the report only confirms what we already know at the grassroots. Every day we hear from women, young people, and marginalized groups whose realities are missing from the national and donor frameworks. The stories that the finding reveal are consistent with the stories we hear, like disrespect, abuse in maternity wards, silence and stigma around abortion and post-abortion care, and midwives and health workers who are overworked and undervalued. We see community-based organizations struggling under funding, struggling with restrictive national laws, and the weight of doing so much with so little. They are forced to work on short-term project grants. This leaves them vulnerable to collapse when donor priority changes. At GIWYN, we don't just speak for grassroots women and young people. We create spaces and opportunities for them to speak for themselves and define their priorities. We mobilize and strengthen the ability of grassroots-led groups through coordination, networking, sub-grants, and direct care to effectively advocate for health at maternal newborn space and reproductive health space. This is what shifting power looks like. Grassroots women defining their priorities, leading solutions, and holding decision makers accountable. I remember when we mobilized 89,000 adolescents, asking them what they want for their health and well-being. The answers were simple: dignity, respectful care, affordable and reliable medicines, access to safe services, protection from violence, and recognition of their rights. If women priorities are centered, power and resources will be shifted to grassroots feminist movement to advance maternal newborn health outcomes, which is the major aim of Bad Justice Initiative. Thank you.
Thanks, Sybil. I mean, I think you have covered so much and, actually pointed to, why that disconnect is there and what would happen. So, it's quite hopeful in terms of, how centering what women want into the health services is important. I would want to move on to Faith, to you. Um, and I think, Sybil has referred to it when she was talking in terms of, the report finding the lived realities. And I think that's quite a potent term, lived realities, like domestic violence, like FGM, like um, disrespectful care, um, which is often missing and disconnected from the national maternal and newborn health agenda. What have been your insights having worked for such a long time? Why is that? I mean, I think we are going to be looking at why this happened. So over to you.
Thank you, Shree, and greetings to you all. Good morning, good evening, good afternoon. Yeah, I joined this conversation with the voices of communities in Kenya who may not be in this room, but whose voices and lived realities of childbirth, violence, and resilience must be center of our discussion today. It's timely that we are naming the gaps between policy and reality and reimagining how power and resources can shift to those most affected. Yeah, the truth is, this reality don't miss the agenda by accident. They miss it because of how we've been conditioned to think about what counts as real data and whose voices really matter. First, what is measured isn't valued. And from our health systems across our country, we celebrate numbers like maternal mortality ratios or skilled birth attendance rate, but they rarely count what women really go through. A mother left unattended or relieving the pain of FGM scars during child delivery is not captured in the statistics because we have been taught to privilege numbers over stories. Women's lived experiences are dismissed as side notes instead of powerful evidence that they actually truly bring. So secondly, I feel that those who are most affected are often least heard. These are the adolescents in informal settlements or women who have survived gender-based violence or are the ones carrying the burden of poor maternal health system. Yet they are least likely to be in the rooms where health policies are shaped. Even when communities are invited to these policy boardrooms or other processes, their participation is kind of most of the time symbolic. For example, a grassroots midwife may sit in the room, but just to validate the agenda that has already been written and not rewrite it. Their realities don't shape regional agenda, not because they don't really matter, but because their voices are systematically excluded from the decision-making processes. Thirdly, there are also some political reasons. Naming poor infrastructure like facilities without running water or electricity or exposing chronic drug shortages or staff shortages points directly to failures of accountability and governance. Highlighting mistreatment of women during childbirth raises uncomfortable questions about training, about regulation. So, and when it comes to even unsafe abortion, the silence is even much louder. Reason because it's a political contentious issue. So rather than confront these realities, governments often push them aside to keep maternal health strategies looking quote unquote clean and acceptable. So while the real struggles of women and girls remain unaddressed at that particular point, the Birth Justice Initiative mapping confirms across Kenya and other countries, obstetric violence, FGM, unsafe abortion, GBV are really widespread, but they are invisible in policy frameworks because our system don't value our lived realities as evidence, and because those most affected have the least power to be heard. In a nutshell, they miss because our definition of evidence is too narrow, our politics too cautious, and our processes too top-down. Until we change that, the maternal health agenda will always have a blind spot for the very persons it's meant to serve. And the very persons meant to serve are those that may not have the opportunity to sit in those boardrooms. We need to speak for those specific people if we have the opportunity, but we need to create spaces for them to speak for themselves because they understand the issues they go through within their own context and they have solutions for those issues. Thank you, and back to you, Shree.
Wow, thanks, Faith. I mean, I think I love your sort of, how you captured in terms of privileging numbers over stories, uncomfortable questions, contentious issues. And I mean, I think that also in terms of that conditioning, it gives me the segue to ask question to Kemi around, power structures and Kemi, from your experience in terms of movement building and your thought leadership, could you talk to me from the perspective of power and how it manifests in maternal health systems, not just in services, but in how money flows and who gets to define what the problems and solutions are?
Thanks so much, Shree, for that. I also say good morning and good evening to everyone. I'm so happy to be on this panel, also with my lovely sister, Sybil, and a great partner of Feminista. Shree, I'm really happy that you mentioned this issue of power. And we need to look at this because it's extremely important if we are to center the needs and the voices of those who we intend to serve, right? And so what we've seen over time is in terms of, and from my experience, right, leading the global advocacy work at Feminista, but also in terms of my work at national level and grassroots level, what we've seen is that a concentration of power exclusively within the health systems itself, and in terms of determining the agenda within health systems. And that's not necessarily a bad thing, because I think in many of our countries, there hasn't been enough investment in health in the first place. And so there was a bit of work being done to be able to bring the health system to a level that can deliver quality services. And I think in our intention to do that, we actually left the most important people, which are the users of these services, out of the conversation in many circumstances. And so we need to start to look back and interrogate how is it that the users, be it adolescents, be it women and children, are actually involved in terms of the decision making around the services that are actually ultimately left for them to use. So it's not just enough about, we know that availability of service does not guarantee access. There's a whole lot of other domains that we need to address in terms of ensuring access, because that's what we're trying to achieve with universal health. I don't want to say coverage, but universal health access. We need to be able to interrogate those elements. And so how do we shift power back to the users to ensure accountability for services, to ensure, and I really like, there is a movement now and a new framing, when we tend to think about maternal and child health, we tend to look at it from the perspective of the 3 delays, right? And now there is the conversation around a 4th delay, and which looks at the systemic elements that prevent people from accessing health services that is nested at community level, and the need to be able to interrogate that. I know that my colleagues, Faith and Simple, have already talked a lot about the importance of inclusion and involvement of communities. I think that, yes, is important as a input, but we also need to look at what are the results and how are they involved in ensuring the results of this. So I know that what we're seeing right now in terms of this renewed commitment, because it's always been there, to ending preventable maternal death, there is a need to really look at I would call it like 4 or 5 key elements to this. I think one, of course, is the shifting of power. I think the second we've talked about is about voice. I think the third piece is about looking at the way services are. We don't live single issue lives. And so we need to look at health systems that are looking and taking a comprehensive agenda, and not just the reduction to a point of, okay, it's only about the ability for women to deliver safely, but what happens even before that, people's choice to choose if they even want to have children in the first place. And then if they do, that they have all the resources to have. So we're looking from everything from contraception to family planning to assisted reproductive technology and support for those that choose to want to have children, to have that support, to the process of easing the support needed during pregnancy and then and post. But also looking at for those that don't want to carry pregnancies to term, what services are provided to them, and ensuring that we look at a comprehensive approach that ranges from contraception to access to safe abortion to maternity care and everything in between. And I think in this process, we need to start to look at how health systems are responsive, because we focus so much in terms of our interventions on the inputs into health systems, the health, healthcare workers, physical facilities, commodities, and drugs. And we're still seeing that that's not necessarily helping us. It's made some progress because we've seen in every country a decline, especially within Africa and Asia, a significant decline in maternal mortality and also an increase in child survival. But we're still stuck somewhere. We haven't eliminated it. Even one death is unacceptable. So how do we get to that, like get over this hump? We've reached, for those of us that are doing exercise and want to lose weight, you get to that weight point where you're not losing weight anymore. I feel like for many countries, like that's where people are at. Like they have not been able to really get to a point where it's negligible. And that's because we now need to interrogate those other systematic issues that are not just only about the inputs into health systems. We need to get to a point now in which health systems are delivering for people based on the diversity of who they are, right? And also based on the resources that is available, and also how people are involved in that process. So I think those are really important pieces. And I think it ties into the work that many of us are doing. In terms of the organization that I work for Feminista, in terms of looking at how do you build a culture of accountability and how do you build movements of women, of adolescents, of young people to be able to hold the system accountable, to deliver for them, because that is the purpose. And how do you resource that? So it's even when we start to think about birth justice, we need to look at not just the formal system, but also how we're empowering users and resourcing users themselves to make sure the system is working for them. And I think that's the amazing work that we're doing, amazing work that I think my wonderful folks at Global Fund for Women as well is doing to make sure that there are resources in the hands of people to bring about these changes. Back
Thanks,
to you, Shree.
thanks, Kemi. Thank you very much, Kemi. And I think in terms of, you raise really important points. And I really wanted to dig deeper into that. You being a feminist thought leader, what are your takes, especially when you say, supporting, looking at sort of the patriarchal hold, looking at hierarchical structures in many countries and within health systems. So, obstetricians, gynecologists are above, say, for example, midwives or nurses or community health workers. So there is hierarchies. Quite a lot of them are men. And, I'm going to call it out as it is. And, so in terms of, getting women who are part of patriarchy, what is the support that is needed so that they can articulate what they are really wanting? Or, first is how do you support them so that they can articulate their wants or needs, and then surfacing them into the health system. So there are kind of a steps. And I think it would be really useful in terms of your insights. I think, one of the things when we were looking at the country mapping report, you used a fantastic terminology. It's like who shapes the agenda. But even getting to shaping the agenda, you really need to articulate what I want in the agenda. So, if you could just elaborate on that, and then we can move forward.
No, thanks so much, Shree. I think you're absolutely right. The health system has become intrinsically patriarchal and hierarchical, in which, and it comes with just history, right? It comes with, over time in which, we have an even though people talk about, we have a lot more women in the health system now, but evidence has shown from the work from women in global health and others that we see women more at sort of like the lower cadre of the system and not necessarily in policy decision making, management spaces. And so I think right now the issue is not even, I think the focus has been about the gender balance in the health systems versus talking about how we're involving the end beneficiaries, women, girls, children, in the decision making that will lead to the outcomes that we want. So looking at things like community health systems and community health advisory boards. I know I'm using Nigeria as a perfect example. You have ward health committees at the community level that are meant to be composed of different voices at the community level to work with the formal health systems, with the clinics, be it the primary health clinics at their community level, to make sure it's responsive. They have done amazing work. Some of these community health, committees, in terms of one, even ensuring clinics are open, flagging when they're stock out in the clinics, and bubbling that up to the local government, because in many countries, health is not on the exclusive list. It's something that is shared, a responsibility shared at subnational level and at national level. They've played roles in terms of mobilizing people to better understand their health and their rights to health, to be able to access these services. But the challenge we've seen over time is with those community health committees, it's heavily male dominated. And so you tend to see less young people, you tend to see less women in those conversations. And even when you start to look at those that are working in terms of advocacy, to be able to increase, like, for example, advocacy around reproductive, maternal, child health, adolescent health, you tend to, it's very male dominated, the voices that you see even at the national level and subnational level. And this doesn't make sense to me. And we need to look at what are the systematic reasons for that. It's the reason why we're seeing that is because there has not been enough investment in strengthening capacity of these groups who are the end users to be able to engage in those conversations and drive the agenda. People are discounting the lived realities that they bring there, and that in itself is expertise beyond the formal, academic sort of process. And so we really and need to look at how to strengthen capacity. There's a lot of conversations right now around local resource mobilization for national domestic financing for maternal, child, adolescent, reproductive health. Um, we need to get more women and adolescents and young people into those conversations, and to drive that agenda and to place intersectional lens to the agenda, because that's another thing that's missing. And make sure that the agenda is truly comprehensive, right, in terms of the wide range of service that we need to end maternal death, across the board. So I think we need to start. I believe bottom up, and I hate that word bottom up, because I think when we talk about bottom, it's actually where people power is. It's about the base and making sure that people can hold. If even technocrats and health policy folks understand that the work they're doing is in service of the community, in service of women, girls, and then they have to switch the approach. And so we need to make sure that these voices are represented at different levels of decision making, from the community health committees to the local governments, to the states or the provinces, and to the national level, and ensure that they're holding people's feet to the fire. And if at the community level it's holding the health managers or the in charge or even the direct health worker that's delivering the service, then you see that services become more responsive. Uh, Really quickly, Shree, one tool that I think has been really interesting in terms of how to do this has been social audits. We have our amazing partner in India, the YP Foundation, that have been building capacity of young people to use social audits to figure out how responsive are services at community level to their needs, their adolescent sexual and reproductive health needs, and bringing that data to engage with their local governments to say, this is not working. We need to have more. And so it's evidence based. The advocacy is evidence based. We need to have more of those things, and those tools at our disposal, and strengthen capacities of movements, of young people, of women and girls to be able to use these tools to do the accountability work.
Thanks, Kame. I want to move to Faith, and ask kind of, elaborating on, the real issues in Kenya, and whether you could give an example in terms of how sort of centering the lived realities in your experience have actually um, improved the outcomes, for mothers, for girls, for adolescents. So over to you, Faith. You are on mute, Faith.
Sorry about that. Thanks. So I like to say that first, we have a big disconnect in our country in between the country's official maternal health policy and women lived realities of marginalized communities. There is a real big disconnect. I want just to give a few examples of that, how that disconnect is shaping out. For example, Kenya has some of the most progressive policies on paper. Article 43 of our Constitution guarantees the right to the highest attainable standard of health. The Health Act defines emergency treatment as the right, emergency treatment as the right of everyone, regardless of the ability to pay. We also have an adolescent policy of 2015 that talks about that commits to providing access to non-judgmental services to young people. We even have a very progressive Mama Linda program, Mama Linda Kiswahili word, taking care of our mother program that promises free maternity care. But in reality, many women in marginalized communities don't really come to realize some of those that have been committed in policy. For example, obstetric emergency, or rather obstetric care, is basically absent. If you look at the 2023 health facility census revealed that only 5.8% of facilities have accident and emergency units, and half of them lack ambulances. 60% cannot even provide blood transfusion. So if 60% of facilities are not able to provide blood transfusion, that means mothers who are in labor going to those facilities will not have the opportunity of getting transfused if they find themselves in that situation of emergency. In some hospitals, we are seeing women sharing beds. That's their lived experiences. While the policy commits to give them dignified care, what really happens to them when they're actually sharing beds within a facility? That is a clear systemic neglect of our mothers. Another glaring example I can give is about adolescents. The gap is very painful. On paper, we have fairly great policies about adolescent health, where we have our constitution talking about everybody has a right to the highest attainable standards of care, including reproductive care. But you find that, for example, a 15-year-old who is in Northeastern province may just not deliver in a health facility, not because she doesn't want, but because they lack transport. They lack even the nearest facility may be 40 kilometers away from where they live. So where does that leave them? It leaves them with poor maternal health outcomes. Then we find that even the data on the Kenya Democratic Health Survey system, the data on pregnancy among 10 to 14, that data is actually invisible at subnational and even at national level. The data that is collected is from 15 to 19 years old. So this invisible erases the youngest and most vulnerable girls from programming, from policy, from leaving them very unprotected and unheard. So the disconnect is very clear. Policies speak of universal access, free maternity, youth-friendly services, but adolescents, the group that has the highest risk, still face a lot of stigma, hidden costs, and quite some disrespect. So we also find that the Kenyan workforce is recognized in policy but abandoned in practice. For example, the Productive and Neonatal Adolescent Health Framework and Community Health Strategy highlights midwives and community health volunteers as key persons in essential maternal health care. However, community health volunteers at times go unpaid. The nurse-patient ratio in postnatal wards is well beyond the WHO recommended standard. In some cases, about 1 to 67, while we know the recommended standard is 1 to 4. So without valuing the people closer to these women, policy promises remain quite empty. Secondly, finally, I can talk about accountability and even resourcing. Our constitution has promised that the government has promised that we need to have progressive realization of our health rights. Yet budgets are cut. For example, as late as sometime this year, the budget that had been allocated to the Mama Linda program was cut by half. So what does that leave us? It leaves us with regression and not progression. And then we keep blaming ourselves why our indicators going south. They're going south because we are not committing. Naturally, we have to invest. People invest where their heart is. So do we stand and say the heart of the government is not with women if they're cutting costs on the lives of women? And what does that lead to? It leads the cost. It costs women their lives by sacrificing that we are not going to fund this aspect of care. We will divert the money somewhere else, but we are losing lives. So I think the lived realities of our women, we need to talk about it. We need to talk about this, discrepancy. As communities, we cannot remain silent while women are denied their constitutional right to safeguard, to safe and dignified care. I'm encouraged that some people, new voices are coming into play, but what investment do we have to strengthen these new voices to be resilient and to be strong in terms of championing for the rights of women in our community? Thank you. Back to you.
Thanks, Faith. And I'm conscious of time, and we are really nearing, getting very fast towards the end of our question and answer so that we can have opportunity for our audience to ask questions. But I want to stay with you, and then I will move on to Sybil. Is then when you talk about, centering the realities, what are some of the concrete actions donors and decision makers can take to make that a reality? How would you summarize that? What should they do?
Okay, I will say that we talk about shifting power and shifting power is not just about moving funds from one level to the other, from one funder to the recipient. Power has many layers, even at community level. My colleague has just talked about part check. We cannot overemphasize that. Patriarchy shapes who speaks, and who decides. For example, in my country, Kenya, our parliamentarians are overwhelmingly male-led. Community leadership is male-driven. The power we cannot ignore because it directly. This power we cannot ignore because it directly shapes maternal health outcome. So we need to innovatively design initiatives that will have women at the center of decision making, women in power positions, and women championing for themselves. I really struggle when I hear that we have male champions in SRHR. I mean, why are we just not talking about enhancing that patriarchy? I don't think a male champion will give a woman space. Women need to have the space for themselves. Spaces have to be designed for women to have their own space and championing for their own rights. And the other thing I also want to talk about is funding communities. Let's embrace trust-based funding. Women testimonies of mistreatment and young people's accounts of, like, for example, unsafe abortions, they are evidence. And some of these small organizations don't have what donors will look at and say, we need structures in place. Let's trust them before system strengthening. Because if you're not trusting them, we are saying we can only fund you if your systems are strengthened. Then we are leaving out those that can really champion some of these agendas, because they have to start from somewhere. If no one is trusting them to start from somewhere, who's going to trust them? We'll leave them behind and continue moving on with those that have been in the space. And still, when we continue moving on those few that have been in the space, we are contributing to segregation, disintegration, segmentation, and the voices that matter are left behind in those spaces. Thank you, Shree. In the view of time, I'll take it back to you.
Thank you, Faith. Oh, Sybil, I really want to come to you. And I really want to ask you, what are your direct messages to the international donor community and policymakers in our audience today, given your experience? And I know that you have worked in, your organization is working with the grassroots level organizations. What is it you think that they can contribute to improving maternal and newborn health outcomes? Thanks. Thanks, Sybil. And Kemi.
Thanks so much. I think what I would want to recommend is that for donors to look at, yes, I think it's important for us to support health systems, but I also think it's important for us to support organizations to do that accountability work. We want to make sure that organizations that are led by the communities that they're meant to serve need to be part of that, need to be at the decision making table. They also space needs to be created for them to engage. And I really appreciate some of the work that some organizations are doing to facilitate that. Um, and so I think if we're able to do that and really allow people to also connect with each other and learn from each other across geographies, across let's because the context and the challenges are quite similar, and so really creating platforms like our Center for Evidence-Based Advocacy that's really connecting people across the global South to sit down and to discuss what it is and what it means to be able to do this work from an informed place. But also, I think by making this investment, we
I think, Kemi, are you there? I think we must have lost Kemi. I know that she was connecting from externally. She is in New York for UNGA. So while Kemi is back with us, I'm just going to actually move on to audience questions. No, she is back. Yes, Kemi, you are back. Sorry.
Yeah, sorry, I thought I got kicked out. But I think I was going to say the last thing is that it is an opportunity for us to also build that grassroots, that grounded support for the issues of reproductive, maternal, child, adolescent health and be able to push back against the opposition to this work. Like, this is really about building people power. So for them to do the accountability and to push against the idea that some of this is not a national agenda, but to reclaim it as this is a national agenda, this is a people's agenda, this is a global South agenda as well. So I see it as having two opportunities for us to have good results. So back to
Thanks,
you, Shree.
Kemi. Yeah, thanks, Kemi. And I think you touch on the sort of, what's going on. People's agenda and people power is so important given the current geopolitics. I think, we really need to make sure that, we are bolstering that people power through, the initiatives that you talked about, the birth justice initiative as well. I just want to take few quick questions. And the first question I have got is for you, Kemi, from Josephine Lavoie, Third Sector Builder Canada. So, what Josephine is saying, the report shows that civil society's role in maternal and newborn health is often symbolic in a world that feels polarized and fragmented. What does radical engagement look like so that grassroots voices don't just appear in the room but actually shape outcomes? So, that's to you, Kemi.
No, thanks, Shree. And I think it's part of what I've spoken to throughout today. I think there needs to be investment in strengthening capacity. I think there needs to be intentional investments and seeing this as an important output in terms of even health system strengthening. Instead of focusing exclusively on building capacity of healthcare workers, in renovations, and bringing drugs and supplies, we need to invest in people as well as part of the health system, the end users, so that they can actually do this work at all levels. And recognizing that it won't have to be the same people over and over again. There will be some people working at the grassroots level, holding the PHC accountable. There will be people working at state level to influence policy and the frameworks, but also resourcing. There will be people working at national level to support guidance. There should be people working at global level to bring national level experiences to global spaces to set this agenda. So I think we need to invest at these multiple levels and strengthen capacity and provide resourcing for movement, because this cannot be only about NGOs. It needs to be about a combination of people and looking at the movement holistically, both organizations, individual activists, um, community-led groups and associations, professional-led associations, youth groups, youth-led groups, so that we have a really strong movement for this agenda of reproductive, maternal, newborn, child health, adolescent health. And I think we need to invest in financing the work, but also invest in financing that capacity strengthening to make this happen.
Thank you. Thank you. Sybil or Faith, do you want to come on to this question as well? Do you want to share anything?
Yeah, thank you. I just want to emphasize that we need to invest in systems. We need to invest in systems for young organizations, small organizations, because they have lived experiences, they have expertise in terms of how they can solve their own problems, but we normally demand numerous items from them, financial reports. Why can't we give them the opportunity for them to write the first financial report? If we don't do it, who's going to do it? Who's going to do it? We need to give them that opportunity. Let's trust them. Let's support in building their structures. And I'm talking about this from my first-hand struggle. My organization, Third Sector Builders, was founded after years of working with incredible grassroots groups in Africa that no one was ready to fund. Not because their work lacked impact, but just because they didn't have the so-called necessary structures. But just because they were too young, too new, with no track record, no one noticed them. Yet they had the power to shift everything, if not everything that was under their mandate. They could actually do much, but no one trusted them. Let us invest in these people. They have what it takes to change the narrative. Secondly, to the donor community, let's fund coalition. Let's not contribute to the fragmentation by funding small pieces of work that are disconnected. They don't speak to each other, because then we are contributing to the fragmentation and not contributing the collective movement. Let's fund networks, let's fund long-term, and let's fund coalition. For that is sustainable as opposed to fragmented work. And the donor community, please let's speak to each other. Let's not work in our own small cocoons and no one knows what the other person is doing, because then we are contributing to the disintegration at the grassroots. Thank you, and back to you, Shree.
Thanks very much, Faith. I think you really sort of nailed it in terms of coalition building, and I must give a big acknowledgement to our funder, the UK Foreign Commonwealth and Development Office, who is doing that. So we have funders who are trailblazing in this regard through our Birth Justice Initiative, because we will be actually doing the coalition building in Kenya and Nigeria. And, I think, kudos to them, given what is happening. They are taking that step, and, we are really grateful to them. I mean, I think one of the things you all mentioned, and I think we talked about slightly, Faith, the other day, is the demands from funders, in terms of, and you all spoke about trust-based funding. And one of the things that actually sort of always has been my bugbear in terms of funding compliances, the funders need to think about, are they actually creating compliant managers, or they are encouraging thought leadership and actual solution to the local issues, which the communities are able to identify their own issues and resolve them as well. So I think that's something, a question for big funders that I would like to pose, who are in this community. And also the other thing which we found in the report is the anti-rights groups and how they are claiming space. They are actually, giving funding based on trust, under certain guises. So I think, it's quite interesting in terms of how the dynamic is now changing. And, given the sort of kind of a dissolution of international funding, how this is going to play out, looking at how, different grassroots organizations are going to build on the agenda, coming from funders. So I think, it is quite interesting. Just looking at time, we have few minutes, so I'm really looking at a question. So I have got a question, and that question is quite interesting, and it is directed to any of you, from Stanley Mbehero, so your namesake, Faith. What policies and support systems should be put in place to assist fathers who are left as primary caregivers of newborns following the death of their spouses during childbirth, which is quite um, a very serious question, and I'm sorry about, yeah. So if any of you like to respond to that.
I'm happy to go quickly and pass on to my colleagues. And thank you so much, Stanley, for that question. I think the first things first, we need to acknowledge that under no circumstances should any woman have to die giving birth. Like, that's what we are in this work to do, to eliminate that at all costs. And it's a fight that I think we're all going to fight for as long as that we can, and hope to see that eliminated in our lifetime. I think the second piece is, this is where social support systems is really important. And this is where I think there is the role of government comes in. I know traditionally in such circumstances, you tend to see the communities step in, especially in the African context, and I'm sure also in the Asia and the Pacific context, where communities step in, when the extended families step in to be able to provide the support. But I think that we have for so long taken for granted states' responsibility, government responsibility in that. And you tend to see in other countries outside of some of the global South countries, providing those social safety nets, right, to be able to support parents. I don't want to, put any gender terminology on this, but to support new parents, period, be that be a father, but people that are playing the roles of caregivers, to be supported, to be able to ensure and to support positive child health and neonatal health outcomes. That needs to be part of the work with the state. Because we also have situations and circumstances in which we have children giving birth to children. Early marriage, forced early child and forced marriage, early pregnancies, and the state has a responsibility to provide the social support systems to be able to address these issues as well. And so I think that needs to be part of the advocacy broadly. But we need to really put our feet on the gas pedal to really end all forms of maternal death, period, as the foundational issue as well. Thank you.
Thanks, Kemi. Yeah, Sybil, you wanted to say something?
Um, and Shree,
Thanks, Sybil.
just a quick one to that. I can't emphasize more what Kemi said. Our goal is zero maternal death. However, for a long time, men have been silent when they're losing their wives. We need male voices. I'm so happy of late in Kenya, I've seen men against maternal mortality. We need those voices. We need men to make noise. We need them to say this is not normal. We are tired of losing our wives, and that has to come to an end. Policies in terms of babies after mothers have died, I mean, that we are here to end. We don't even want to have those policies of take specifically mothers that have their baby, the mothers that their babies died. We want those mothers not to die. So that any other policy on neonatal policies, it's comprehensive, not specifically for the ones that have, no, we don't want to go that direction. Mothers should not die giving birth. That has to come to an end, and male voices have to be part of this campaign, zero maternal death. Thank you.
Thanks very much, Faith, Sybil, and Kemi. We are almost at the end. We have 3 minutes to go to finish this wonderful webinar. I know that there are more questions from the audience. Unfortunately, I couldn't take all those questions and share with you, but just to reassure our fantastic audience that we are going to take those questions away, we will put them to our panelists, and we are going to circulate an email after this webinar, and we will try and address those questions afterwards. So be patient with us. I think, that's it really. What are the next steps? So we are continuing with our birth justice initiative. We are digging deeper in terms of identifying the grassroots actors in Kenya and Nigeria. You can download the country mapping report, which will give you more granular information about how we went about it, the methodology, what are the findings, what are the insights, with all the references. Please follow Comotion, Global Fund for Women, and the incredible speakers on today's calls. My colleague is actually putting the the links through as I speak. And yes, please join the Birth Justice Initiative community. I also want to finish this webinar on the note, the call to action for the donors and key stakeholders and community and our partners in the audience is that there shouldn't be these two siloed worlds, which Rachel when she talked about connecting these two worlds and connecting these two worlds in terms of health system reform, health system strengthening, um, embedding justice driven demands. And I think why is that? Because it is efficiency, to achieve efficiency and effectiveness. And I'm talking from an economist's point of view, because if you embed the justice driven demands, what communities are telling you, you're targeting it better. That doesn't mean that you need to find more, one more pot of funding, one more. It just, how do you actually target better? If you start targeting better, if you bring, how to address gender based violence, how to ensure that women's voices are at the center, you will achieve transformational results. So it is about connection, it is about efficiency and effectiveness, and it is actually maximizing the value that your investments are getting. So I'm talking in economist term, but I hope there are certain people who are here who can understand that language. And on that note, I'm going to thank again our panelists. Thank you very much for that. Thank you, Rachel, for opening this webinar. And I'm really delighted and, have been really honored to be part of the journey, and, and we will continue this journey. So thank you very much.
Thank you very much. Thank you.
Thank you, everyone.
Thank you, everyone.
Excellent moderation, Shree.
Bye.